So this started out as 3 questions, and it's the 3 questions I asked people who were involved in the heroin impact response team that has changed its name somehow to the Heroin Response Task Force, and it goes by the acronym HIRT, H-I-R-T. And the questions were essentially what occurred in 2014, the first year we were sort of in business. What do we expect to occur in 2015? This questionnaire was sent out in early December of last year. And then what are the barriers to accomplishing the things we would like to have accomplished that we haven't accomplished already? Here's my contact information and the 2 websites that I like to promote, Drug Free in Northern Kentucky, nky.org, and Northern Kentucky PAR.org. PAR being People Advocating Recovery. Okay. So, I took a class here, like Frank, a few years back, and it was a videography class, and we were out to ask to just do something crazy. So I went around the campus asking people what a certain word meant, and it was called, I was asking what entropy was, and it was a crazy sort of responses I got. I am an enigma, I can tell you that. I'm a person or a thing that is mysterious and puzzling. This position that I'm in is certainly very mysterious and puzzling to me. Go ahead, I'll explain why. Because I started out teaching here a few years back. I taught here for 10 years as a part-time instructor. I basically had my own curriculum and my own syllabus and my own organization within the kinesiology department. It was called Adventure Education. And I got to teach canoeing, kayaking, backpacking, and the high ropes course, which is now BB&T's, whatever it is over there. I missed that high ropes course. Anybody in here ever had the opportunity to get on the high ropes course? That was a great gig. 2 or 3 times a week, get out there and watch people get scared being up high in the sky and doing the team building activities. I retired from my outfitting business and sold the business to a young lady, a single mom, and about 3 months into her running the business, she was diagnosed with stage 3 breast cancer. Double mastectomy, cancer came back, more treatment, cancer came back. I had to buy the business back. But in the meantime, I was trying to get out of her way, so I went and took a job with the health department as a health educator, and I wrote a grant for a pink boat, and it was a dragon boat. And I got very much involved in this dragon boat activity, and we have a festival here every year. And I was actually at Interact for Health taking a course in nonprofit fundraising for the purpose of helping to support the Kentucky Thoroughbreds, a breast cancer survivor dragon boat team that travels all over the United States, now all over the world, competing in dragon boat races with breast cancer survivors. And while I was there, I got a phone call, and it just so happened the instructor was teaching a 3-hour graduate course on nonprofit fundraising. He was about to cover the topic of events, and since I had been involved with Subaru for many years in doing events all over the United States, I was pretty confident I could put on an event. So I took the call because it was from a boss. She said, "What are you doing?" I said, "I'm on vacation." "What do you mean you're on vacation?" "I'm on vacation. I'm taking a course with Indiana University." She says, "What's the course?" I told her. She says, "Well, I'm calling about that job that she asked me to write a letter on behalf of Northern Kentucky Independent Health Department from Three Rivers District Health Department in support of housing a part-time coordinator for the Heroin Impact Response team at that time." And when I wrote the letter for her, I actually told her, I said, that job description is for a part-time position, it's set up for failure. We can see it. I'm good. It's just, like I said, it's going to bother you people more than it's going to bother me. But what happened was, she went to the county judges in the lower counties and said, "Can we pull some funding together to make this a full-time position?" So when she told me that, I said, "Wow, that's great." She said, "Well, only if you take the job." And I was like, "Hey, wait a minute. There's a lot of other people who, and there certainly are a lot more people qualified than I am to do this position." But it just so happened that the person who paid the other half of the salary was walking by as I was talking to Dr. Heiss. And I said, Ann Barnum, this is Dr. Heiss, and I told her what was going on. She says she was concerned that whether or not I would have a job after this gig, which was 1 year, was over. And I said, no problem. July 1st, 2015, I'm retiring. I can do this. It was a 1-year job. I'll do it. That's what I thought anyway. It's changed a little bit from that. So anyway, I accepted the position and it was approved and I went into work. And part of the reason I got into this was at a dragon boat practice, this gentleman shows up with his team and he says, hey, I hear you're involved in prevention work and you're working with tobacco, getting people off of tobacco cessation. We got to talk and we talked about resiliency and the next thing I know, he's calling me up on the phone quite a bit. And I was so grateful to be able to introduce him to Dr. Hedrick, and she was able to take some of the calls. This gentleman, Dr. Jeremy Engel, is the reason why we have a heroin impact response task force. He's basically the reason why we have the plan, although Bonnie put an awful lot of effort into that plan as we put it together. And so with his help and with her direction and in meeting Jason over here, and Jason taking off and running and creating this thing called PAR in Northern Kentucky, it was just a whirlwind of activity the first year. Go ahead. So how did we get here? And some background. How many of you were able to go to the mummy exhibit over here in Cincinnati Museum? Did you listen to it all and read it?
I looked at it more than listened.
Yeah, okay. There was a 7,000-year-old female from Chile who, and there's a desert in Chile where they have all these mummies. And actually these mummies are deteriorating because of some climate issues. But this mummy was over there and somehow or another, you recall, they were able to determine like what they ate.
Yeah.
That they found this lady had opium in her system 7,000 years ago. We've been doing this this is not new. So, and then the question becomes, is it a disease or is it a choice? Is it just part of our human nature to start using this stuff? And then does it work for some of us and for others it doesn't? I don't know. But this gentleman, Benjamin Rush, who was our nation's first, what's our doctor? Surgeon General, thank you. Yeah, I got it right up there. I should be able to read that stuff. All right. He was really concerned about the Continental Army and the amount of alcohol they were consuming. And he determined in July 4th, 1776, he was making a statement, this is a disease. My wife worked in this field for 30 years. And for the 30 years she worked in this field, she'd come home and she'd tell me what's going on at the care unit. And I'd say, these poor people, they just, they're a moral failure. They just can't make the right choices. I was telling her it's a choice. She was telling me it's a disease. We'd have arguments on this for almost 30 years. This guy back here said it's a disease. In 1800s, morphine came out, and that was a good thing for the battlefield. Thank you for your service, I assume. In 1998, heroin was produced by Bayer Pharmaceuticals, Bayer aspirin. It was produced and trademarked as heroin, a German word from the German word hero, because it made people feel like heroes, I guess. And in 1914, we had this Harrison Act because this was supposed to be a cure for more, it was not supposed to be addictive, and it was supposed to be a cure for something else in public health. It was a really bad situation back in those days, and that was tuberculosis. And it was a cough suppressant for people with tuberculosis. But all of a sudden, people were getting hooked on it, addicted to it, and for the most part, it was women, because women weren't allowed to go into the bars. They were all stag kind of cafes. So in 1914, Congress got together with the Harrison Act, and they put control over all opiates and stopped the over-counter sale of heroin and other opioid drugs. And during this next 10 or 15 years, it was really amazing. And I think that this has stuck with the medical community because of what happened. 22,000 licensed medical doctors were arrested because they were treating people who were addicted to heroin with morphine, which was illegal according to the Supreme Court. Over 3,000 of them lost their license and went to jail for doing this. And all of a sudden, we went from seeing this as a medical problem to this is now a judicial problem, a criminal problem. And it's pretty much stuck with that all the way up to 1970. We began to see a little switch in the gears. People were beginning to see it as a medical problem again. But then all of a sudden we come back with what we claim to be the war on drugs. So, historically, drug use swings from uppers, cocaine, to downers, opioids. And there is this pattern of swing in between. And most of us in this room are old enough to have seen it go from methamphetamines to heroin, right? There's all the rounders, all-rounders out there. Was anybody in Chicago last weekend? The last of the Grateful Dead concerts? Anybody been to a Grateful Dead concert?
My husband's been to 27 shows.
It's a lot.
And my husband is a huge Deadhead.
Yeah.
And he wanted to be there, but it's sold out.
Yeah, I wanted to be there too, but the tickets were too daggone expensive.
Yeah.
But you know, anybody that went back in the 80s and 90s, you know that you could just breathe in and get a contact high from the amount of marijuana that was floating around. So you got the mushrooms, and LSD has always been around, and they're always around even when these other drugs are high on the priority list. The Mayo Clinic researchers have found, and this is just research that was released last week, have found that 1 in 4 people who were taking prescription painkillers for the first time progressed to long-term prescriptions. Dr. Kalfas will tell you somewhere between 20 and 23% of us, by virtue of our genetic background, our genetic makeup, have a predisposition for becoming addicted to opioids. So think about that. That's like 1 out of 4 or 1 out of 5 for sure of us, just by virtue of going to the dentist and getting a Percocet or a Vicodin, could find ourselves in a bad situation. My wife taped a movie for me over the weekend. I watched it last night. It was called Perfect Tie. Anybody seen that? It is a true story about a young lady who had knee surgery who was given hydrocodone and ended up a heroin addict. 15.9% of our population would become addicted. That's something like 50.4 million, and it just, people get better and people get worse. Go ahead. 31.7% of us use occasionally and are on the verge of possibly becoming addicted to something. The cost currently estimated to be $60 billion in lost wages, in hospital costs, and criminal costs, $60 billion to our economy every year.
600.
600. Thank you. I used to teach math. Now you see why I don't anymore. Okay, Kentucky House Bill 463 and then Castro, Kentucky House Bill 1 put an end to pill mills. And our Attorney General, Jack Conway, went to Florida, got with the Attorney General down there and shut down the pill mills. We had people flying from Cincinnati down to Fort Lauderdale. On 11th Avenue, they had a dozen places that they could go and fill up prescriptions one at a time and come back with Oxycontin and sell it, right? That suddenly dried up the street drugs for heroin or for opioids. And when I say opioids, I'm really talking about heroin ultimately. Because the brain doesn't, heroin in the brain becomes morphine, everything else does too. So we're really talking about the same thing. Heroin comes in, and I'll mention this later, but while it's on my mind, I'll tell you right now. Book came out in April. I highly recommend it. If you really want to get a good grasp of why we have the problem we have here right now, and the perfect storm that led up to it, get Sam Quinones' book, Dreamland. And he, believe it or not, he gets the motivation to write the book, meeting a woman who's a member of PAR, I can't think of her name right now, at Herb and Elma's restaurant on New Year's Day in 2013. He was looking for a place, he found a greasy spoon, and he went in there, and they said, "You're not from here, are you?" He said, "No, I'm from Berkeley. I'm thinking about writing this book on this heroin epidemic that seems to be going on in this area." And they started telling them their personal stories, that they knew somebody, or they had somebody, or they were somebody who had been involved in this, and he said he knew he had to write the book.
What was the author again?
I'll have it up here in a second, but it's Sam Quinones, yeah. And it's difficult spelling. It's a Hispanic spelling. And he has a Mexican connection background, which makes the book even more interesting because he actually goes to where all this is coming from. So with this complex psychosocial and deadly drug, I heard somebody say didn't hit rock bottom earlier in the introductions or weren't quite ready there. But the problem with heroin is, an opiate, is the rock bottom could be 6 feet under because we never know what we're going to get. It'd be sort of like if we still had prohibition and we went out to buy some alcohol and we would know if we're getting grape juice or moonshine and what can happen to us when this happens. The disease of addiction. The new use of the term substance use disorder, and I'm desperately trying to stop using the word clean. Because I think the stigma that goes along with clean is if you're not clean, you're dirty. And you're not dirty, you got a disease. Or maybe you just have what another gentleman, Johann Hari, says is a condition, like a heart condition, right? So come along from that point with all this background and history on opioids, we come to our situation here in the plan. Go ahead. I love this graphic, because we got a group of us together and we had some funding to have a facilitator help bring all these different people who are members of the Heroin Impact Response Task Force together to say, bring their expertise and say what we need to address. And we knew, Bonnie and I were up there, and the Attorney General, I met him again a couple of weeks ago, and he didn't use the word prevention in this whole presentation, so I had to go up and say to him twice, you know, you gotta put prevention in your presentation. I feel that the earlier we can get to people who might be predisposed to this and give them the tools to live with, they might be able to prevent becoming exposed and addicted. But you know what? They can. How many of you have heard of the 40 developmental assets? You ought to look up into that. 40 Developmental Assets Search Institute. Go take a look at that. All right? The more assets a child has, the less likely they are to engage in risky behavior, and the more likely they are to have a healthy lifestyle. 40. Our average in Northern Kentucky is 18. The more assets a child has, the more resilient they are. The more resilient they are, the less likely they are to engage in or become addicted to some substance. But how do you know, I believe there are people probably sitting in this room who had 30, 40 developmental assets. Some people who had 30-something assets who are dead now because they were high-risk takers. They liked to take risk. Or somewhere in their background they had an adverse childhood experience. Again, Johann Hari talks about that research that goes on to explain ACE, the adverse childhood experience. So it's a real complex issue we have in this work on prevention. So if somebody gets into the process of addiction and the brain chemistry changes and they are addicted to a substance, we need to help protect them. And this is where harm reduction, there's a lot of that. I love harm reduction. I wish we'd have called this harm reduction. And then we have to get them, once we get that, Dr. Engel said, stop the dying. So what do? We went after the naloxone. And this gentleman here, how many kids did you guys put out there?
Over 500.
Over 500. How many saves do we have now for
27.
27 saves
That we know of.
And later on, we'll look at what St. Elizabeth has done and the saves that have occurred there. So once we get them and keep them from catching hepatitis C, HIV, and all the other things that could possibly happen to them, and we could try to get them in treatment. How do we get them in treatment? Is it medicated-assisted treatment? We start with Vivitrol, we go to Suboxone, we end up with methadone, or are we completely abstinence-based? It works for some people. These are things that somebody smarter than I am will have to determine. And then the most important thing we find with opiate addicted individuals is you can't do it in 28 days. You can't do it in 90 days. Dr. Kalfas might tell you it might take a year to 18 months before the brain is back to functioning normal again. And in that time, we need to support these people with wraparound services and peer support and things of that nature. And we have on the outside advocacy, we have Senate Bill 192. If you would have asked me last year at this time if we would have had the bill we have right now, I'd have laughed. It isn't going to happen. We weren't happy. We were just happy to get Senate Bill 5 that didn't pass back into the mill and get that done. We certainly weren't going to see a lot of the things that we see in Senate Bill 192, which I'll go into later on. But the advocacy that was done down there, it was not done by individuals like me who get paid to do some of the things that we get paid to do. And Dr. Hedrick, she's got a job with working with the prevention coalitions throughout the area. We are only allowed to do so much. And then, you know, I was told, don't even give the 800 number. And how many meetings did we go to where I just go ahead and give the 800 number? I wasn't looking for this job when it came my way, and people needed to do something. But what made that happen was a lot of parents went down there on their own nickel and their own time in that miserable winter that we had in a short 30-day session. And they were there knocking on doors and telling people what needs to be done with their new heroin bill. And I was told in January and February in local meetings here by our senators and our representatives that there will be no needle exchange language in any bill coming out this session. And one told me there'll never be. He just had an op-ed article in our local paper. Senator Schickle said, as long as I'm around, there will be no syringe or needle language, period. But it just so happened we had a couple of people sitting and one testifying at the House Health and Welfare Committee when what happened in Scott County got international attention. My ex-son-in-law, everybody in my family, if you've been part of our family, you never leave. Even if it's your ex, you're there. You know? And he sent me a Facebook message from way over in one of the countries where he's working as a lower level diplomat. And Doug says, what the heck's going on in Indiana? 26 cases of HIV. Dr. Sadler contacted Kim Moser, who was testifying, and Kim said, oh, by the way, one of our neighboring counties bordering Kentucky and Indiana has this outbreak of HIV from intravenous drug use. Now, all of a sudden, that got on the representatives and the senators' radar screen. So, and the other part we've been trying to do, and you'll see some numbers coming up on reduced supply. But my guess is, and again, you can argue this with me if you don't, these are my opinions, I'll tell you, this is my opinion. If we got rid of the heroin today, black tar heroin in this area today, there would be people in their kitchens making crocodile tomorrow. If you don't know what crocodile is, look it up. It starts with a K. It's ugly stuff. So, go ahead.
Before you leave that,
Yes, ma'am. I was hoping you could.
give you a little breather here. So there's 6 components there, 4 in the middle and 2 on the outer ring. You will get information on 5 of those things, all of the stuff in the middle, and then the advocacy. Reducing supply, we do not have anyone from our police departments coming to speak to you, but we will have a little bit of information to share. But we lost someone very important in our Northern Kentucky Drug Strike Force, and since then, I haven't been able to get connected to them really good.
Well, you'll see my slides. I'm not connected with them either. But I can tell you right now, I've attended a couple of the meetings that Jason has done with, and Christy have done in the trainings of police officers. And you guys are hearing their side of the story. So I don't think they'll be too missed out.
In fact, that's great that you mentioned that. Jason and another one of your fellow social work students, Christy Blanchett, have been so instrumental in reaching out to the law enforcement that they can, for harm reduction, that will be some good information. But we have enough background information on just where it came from, why it's here, and are we making any headway in reducing the supply, that kind of thing, that we can share. We just didn't create a module around it.
Right.
And
Well, I should say, go ahead.
And we do call, protection is now called harm reduction.
Yes.
That we have evolved into. It was kind of a risky term, you know, like 2 years ago. Harm reduction was very controversial. So now that the public opinion has shifted more towards accepting of that type of policy and those type of programs, you know, we're openly harm reductionists.
A couple things along those lines. Kenton County has now agreed that all their police officers will be carrying naloxone. And what is the police officer's name in Hamilton County who has now gotten?
It was Grant County Sheriff.
No. I'm talking about the gentleman over who wrote the editorial and is working with Interact for Health, who's now got police officers in Indiana, Ohio, and Kentucky all kind of working together. You might have caught that on the news. So, you know, heroin doesn't recognize borders. And this gentleman they have agreed to shared jurisdiction. But you know, we do have 2 police officers who have used naloxone now to save a life.
I think I read about that. I think there was a story on that where
The regional task force,
Yeah.
which is such a step in the right
Oh,
direction.
God, yes.
And that, I don't know his name, but there
It'll
was
come to me.
one police officer from Hamilton County. And you asked earlier, Carly, is that right?
Yes, you're right.
You asked earlier about the regional kinds of work that we're doing. That is a good example of it. That it started with one police officer, but basically he's formed this regional task force that is helping to cross those boundaries, those geographic boundaries that are so very important to cross when you're talking about the influx of heroin in our region. Because
The lines of communication have
I think
opened
I
up.
remember, I forgot about that story, and you brought it up, and I'm like, I think I answered my question.
Well, if you saw it on the news, it's pretty interesting. 'Cause
Yeah, I remember.
all the police officers' faces were blurred
Yeah.
because of the roles that they're
Right.
playing. They didn't want the word to get out. But the people who are really involved in it, if you get into Sam Fernandez's book, the people who are really involved in the black tar heroin coming out of the northwestern part of Mexico, they don't want to be, they're really low key. You won't see them driving fancy cars, and, you know, they're basically there as the Domino's pizza delivery of heroin. Go ahead. So, overdose deaths in Kentucky. Unfortunately, all I have is the 213 numbers. I was on the phone with Terry DeMio today, and she and I both lamenting the fact that we have these numbers from St. E's, and we're starting to get these numbers from other hospitals about overdoses that are coming in, but we're not really getting the coroner's information that we feel is so important to correspond with that data. So in 2013, there were 1,019 Kentucky overdose deaths. That's down 9% from 2012. Of the 2019, of the 1,019 deaths, 882 or 87% were declared unintentional. Suicide by heroin is and does occur. As a matter of fact, since I began talking here tonight, we have had 3 deaths from overdoses in the United States. That's scary, and that's the most recent statistics. In 2013, we had the second highest overdose rate in U.S., 23 deaths per 100,000 compared to 13.8, so it's almost double. So the opioid remains the highest cause of overdose deaths. In 2009, it exceeded car crashes in our area. Go ahead. Heroin accounted for 215 deaths in 2013, up 50% from 2012. So it's become a major player in the opioid deaths. From 2011 to 2013, the residents of the following counties were at the highest risk of overdose deaths involving heroin. Campbell County, 21.4 per 100,000, Kent County, 13.4, Boone, 11.3, Fayette, 5.2, and Jefferson, 4.8. University of Kentucky has estimated the cost to be $6 billion. It's a coincidence between the $6 billion and $600 billion to our state, $600 billion to the U.S. with 1 death every 13 minutes. So actually, there's 4 deaths. I'm sorry.
And the most recent data furnished by Michelle from St. Elizabeth is on our website now. So.
Yeah, that'll be coming up here in a moment too.
Oh,
Go back. Did I do that? Yes, go ahead. So, and there's our most recent release. This is preliminary data. Here's what's going on in our rural communities. It might even be going on up here. Coroners are by law, if there's a heroin connection to the death, must report it. But if you're in a rural community like I'm from, like Owen County, where Bonnie's from originally, and you're the coroner down there, you are also probably a good friend with a lot of people in your county. When we lose somebody in Pendleton County, most people know somebody that knew somebody if you didn't know them directly. So I know for a fact that people have been found with needles in their arms, and our coroner has written down heart attack, 26 years old. Respiratory failure, 23 years old. Because they don't want that stigma to get out. But in protecting the family, we're also protecting the influx of the heroin impact in our communities. Go ahead. So we talked about supply reduction and the result of what happens when we go out and capture these people. Here's the rise in northern Kentucky counties each year for rising jail population since 2010. And as you can see, these numbers tend to go up right with the numbers of encounters with actual heroin. Go ahead. This is the most recent slide. This is through June of this year. Obviously, this is 6 months into the year, so if we double this, we're going to be substantially higher, and we see this linear graph actually turning vertical, geometric. Go ahead. This, I hope Terry doesn't say this one, and write this out. But she was asking me about this today. She catch up with you too? Okay.
Yeah.
But here's an interesting thing. It's like how much this dropped in June, and what caused that? And I told her, I said, if my job depended on what was going on in this graph, they should have fired me a year ago when I first started this. I mean, this was the first one that really just blew me away. December, we went to 123. It dropped a little bit in January, then it was right back up to 122, then dropped a little bit, then look at May, 132 overdoses, not deaths, overdoses. And the amazing thing is, these people are alive because they got to the hospital. Now, what happened here? I want to hear your speculation as well, but I know that right in here, St. Elizabeth's began giving these people naloxone kits. Maybe. You got a bunch of kits out. We got police officers got kits. Maybe that had something to do with it. But hopefully those people, if they're using them at their location where they overdose, are also getting some kind of medical assisted treatment as well. We don't know. It's a real anomaly to drop by more than 50% in 1 month.
I'm sure it has nothing to do with the naloxone.
Nothing.
I just wonder what
Sarcasm.
the class thinks.
I do too. I threw this out to you. You're more than welcome to throw it back at me. Why do we do? This is.
There has to be, well, one, it's gotta be some sort of change as far as treatment, like you said, but you weren't for sure, you didn't think so. Or the statistics are not accurate.
Well, the statistics are accurate. This woman, Shell Kreutzkamp, God bless her. She
She hasn't missed a beat.
no,
Okay.
she's got it together. Let me throw one at you.
Okay.
They started cutting the heroin, so you're not getting as high a dose. We had one confiscated at the Brighton Recovery Center out in Florence, and they had tested it. It was 95% pure. Well, that was back in this time. Now, what if they cut the
So it's not as pure now.
I don't know, speculation.
Yeah. But you had another thought though, Carly. What was that? And you were going through it, the statistics could be off, but then did you have any more thought?
Well, I was thinking about something on that line, but I really wasn't for sure, but you kind of
Well, and again,
explained
it's
it really
speculation.
spot on, because I'm learning a lot about this. I know,
Here's the scary thing.
I don't know a lot
We don't
about
know what the
heroin, but I
coroner-
wanna know.
We don't know what the coroner's going to tell us here. I wish I did know. Did this all of a sudden were the coroner deaths here down and the coroner deaths here up?
Yeah,
We don't know.
don't wanna-
With the data that's, we gotta get the data. And it's been like pulling teeth to try to get this data. But it's coming, it's working its
So-
way into the system, yes ma'am.
So is that only people who overdosed and lived? So
This is
you're
only
saying-
people who showed up, overdosed and survived.
Oh,
If they came in or died,
Yeah.
then that doesn't get on the chart.
That's a different statistic.
Right, yeah.
And there's another component with the overdose deaths in the coroner correlation, is that, and this is policy that needs to be changed. We need to work on a solution to this as advocates, as social workers, as community members, as people that are concerned about this epidemic. And it's that when an individual dies of a heroin overdose, life insurance policies will not pay off. So the coroner is more likely to rule it as a heart attack or respiratory arrest or something like that in protection of the family, not just the shame and stigma, but also because they want that family to be okay. And there be, no funeral, no services if there's no, unfortunately.
So if that person dies, but technically, in reality, it was from heroin, and the coroner claims it as a heart attack or respiratory failure or whatever, that person does not make it into the statistic because of that?
Well, the only people who are on these statistics
Or
are
the ones who survived? That's-
who go
okay.
to St. E's and survive. Here's a whole other part.
Well,
Here,
yeah.
another part for this, all right? Well, where do most of the people in Kentucky get their heroin? Ohio. Cincinnati. They use over there, they overdose over there, where do they end up? UC, Mercy, Christ, you see what I'm saying?
So you're not getting that from
We're,
Kentucky?
exactly, and if you're in Pendleton County, you might end up in
Harrison County.
Harrison County, and they didn't start counting until,
Lexington.
in Lexington, they didn't start counting until about 3 months ago. So that's another interesting,
Carly, you were pretty, could be spot on in that the data is skewed, not because of Michelle's lack of
Right.
recording, but
Right.
because of all these other components, all these other influences.
That add to her data,
Yeah.
so, yeah, outward.
Yeah, when we started, it was the only thing we had. And in fact, probably still is the only thing we have. We don't have any idea in northern Kentucky how many people are on heroin.
we don't. We know how many are at the methadone clinic on Madison Avenue on any given day.
And that exceeds 1,000 people now, doesn't it?
1,100, the last night he told me. The other thing to keep in mind with these numbers is the average cost of an emergency room visit is $30,000. Who's paying for that?
Yeah.
Go for it. This is another, oh boy, this is tragic. Women who are using and addicted and pregnant, and if they don't get help, the babies are born addicted. And we don't know what the long-term consequences of that are going to be. We have a superintendent out in Boone County who's already beginning to see behavioral problems in preschool and early elementary school of children who were born to mothers who were addicted to opioids. And here we have in 2014 almost $250,000 again of cost, $18,000 per baby born. Go ahead. So this real quickly, it hasn't changed much. The bottom line is down here somewhere. For every person, 100 people who want to get help in northern Kentucky, 23 or 24 of them are likely to end up getting it. 76 will be told there's no bed or no IOP service available, no medicated assisted treatment available. We are seeing more doctors getting certified to provide Suboxone. We are seeing more doctors becoming aware of Vivitrol. We have a methadone clinic in Covington, but many things have not changed dramatically since this chart was developed back in 2013. Go ahead. This is what it looks like by region, and as you can see, our Midwest region has the highest in 2013 deaths by heroin. Go ahead. So a 2011 survey by the Centers for Disease Control and Prevention shows 5.2% of Kentucky's high school students reported using heroin, nearly double the national average. By the time the teens hit their senior year, use had grown to 7.7%, nearly 5 points higher than the U.S. average. However, in northern Kentucky, I can say those numbers are not that high. And we're very fortunate for that, because KIP data, the KIP surveys just asked this year whether or not they had used heroin recently, and the numbers were less than 1%.
But in some counties, it was double that.
Yeah. So, there was $19 million in settlement funds distributed through the northern Kentucky. These settlement funds were from Purdue Pharma and another pharmaceutical that was producing opioid drugs and selling them, pushing them, and allowing the pain mills to, encouraging the pain mills to be developed throughout the state. And that money was distributed throughout the state. Go ahead. You can all look this up, but here in Kentucky, or in our area, Children's Home got 1.5 billion, and that provides services for children, foster children, got 1.37 million. Go ahead. And these are some of the others. You can look this up online. The money all adds up to about $19 million. Go ahead. Nice. All right. There's final settlement at all. If you, real quick with your calculator, it's 19 million. Okay. What were the most significant accomplishments of the Heroin Impact Response Task Force in 2014? All right, I asked the top 10. So it's sort of like a late night show. Top 10. What were they? Number 1 was we raised awareness, the media, the grassroots, the town hall meetings, and school programs. Almost every county had at least 2 town hall meetings. Terry DeMio, Scott Wartman, a number of writers in the northern Kentucky area, at risk of their careers, continued to produce information about heroin and raise the awareness. Go ahead. Naloxone distribution, I should say, one of the raised awareness. Northern Kentucky hates heroin. How many have not seen that sign? Nobody. Yeah, so everybo's seen it. They've done a great job of getting awareness out. In their race last year, they had 1,600 and something. This year, they had 1,602 last year, 694 this year. That shows the kind of support the area has to bring about some kind of awareness of what's going on with the opioid. Naloxone distribution, trainings, Casey's Law Info, all this began to occur in 2014. I'm very proud of the fact that our county judge executive, former county judge executive Henry Bertram, offered a very cold and dismal room to Dr. Jeremy Engel and to Jason and Parr, and they were distributing. We were the first in Pendleton County to distribute naloxone in the state of Kentucky. Right. Continued commitment of the task force members. The fact that these people, 30 to 40, representing 30 to 40 different organizations, show up on a monthly basis throughout the year, they thought that was pretty phenomenal. That was number 3. Number 4 was funding. And I'll brag about this lady here. I got emails from her, and they're on my computer, 3 o'clock in the morning, and providing ask and grant writing opportunities that we were able to get $500,000 from RC Door to cover advocacy, prevention, and a good portion of what we're doing now with the, matter of fact, I even have some in my, I think I got the, I might have them. You can, this was a big, big deal. Do you realize that officers police officers who work in an intravenous drug environment, 1 out of 3 will get stuck by a needle just going through your purse? I was putting in a car seat at a health department, reaching down to find the latch, and there was a needle. 1 out of 3, 28% of them will get hepatitis C or worse. So what we were able to get through the grant was these gloves. I'll pass them around. I want them back. They got like a Kevlar. I tell the officers, make sure they don't try to catch bullets with them. It's sort of like their vest, but you can feel the stiffness that's in here. Pass out. All right. You want to say anything about that?
That is just a great example of harm reduction in action. We're reducing the harms associated with intravenous drug use among law enforcement and better serving our communities. I'll talk more about the training and whatnot in the next module.
Yep, next one. Greater access to medication-assisted therapy. We do have more doctors providing Suboxone, although recently, because of some 2% of the doctors in Kentucky who are licensed to give out Suboxone did something very bad, and all the rest of them are paying for it. And they've changed some of the rulings of that. I'll get into that again real quickly in a minute. Go ahead. So the next one's, I came in 6th. Legislative advocacy was another one, reducing stigma with people sharing their stories, increased treatment in pregnancy, and singleness with healthcare Core 12 program. Next. So what will be most likely happen in 2015, we're halfway through, that will reduce the impact of heroin. Increased access to treatment. We have SUN, I keep forgetting what that acronym stands for. Huh?
Oh, it's just labeled Sun Behavioral Health.
Yeah, Sun Behavioral Health, it stands for being able to take the next step or something like that. Senate Bill 192, what happened up at the Children's Home in Northern Kentucky with the funding there, and we have a bill called CARA, Comprehensive Addiction Recovery Act. Senator Rob Portman's got it going with Senator Whitehouse. That will provide a lot of federal funds for treatment and for prevention. The omnibus heroin legislation, Senate Bill 192. Legislation that increases access to naloxone, Narcan, Senate 192 did it. Pharmacy Board came on board, and they provided approval for pharmacists to give out or to issue naloxone like they do flu shots, which is very unique in our country to be able to do that. That was a real big step on their part. Increased prevention efforts. Bonnie will tell you more about Core Life, and one I don't have up here is the youth push, and I love it. All right, and there's more for prevention in Senate 524 on the federal level. Reduce stigma through education, again, Senate 524. Go ahead. This was done in December. A lot of the people I surveyed said nothing was happening. They kept hearing it's a short session. They're not going to do anything. Besides, there was like 6 different pieces of heroin legislation, and they went from one very liberal to one very conservative. Put them in jail, and then give them all treatment, and nothing in between. And it didn't look good. So some people felt, a good percentage of them felt nothing would happen. Infection prevention local option, which was somebody actually saw that coming in December. Addiction certification class at NKU, yeah, there you are. And that was also paid for, as Dr. Hendricks said, through the part of the grant. Broad-based Good Samaritan law, we got, folks, if you're advocates and you agree with what we've been talking about thus far, please get on board. We have a couple of people here in Northern Kentucky who want to remove the Good Samaritan language from Senate Bill 192. And not if people call for help, they'll be arrested. Law enforcement training and equipment. How many people have you trained? How many law enforcement?
Altogether, over 1,000. 300 of those being law enforcement.
Okay, they predicted that would happen, and it has happened. Go ahead. So Kentucky lawmakers, this is a great article in the Huffington Post. Lawmakers passed wide-ranging legislation to combat the state's heroin epidemic. The bipartisan measure represents a significant policy shift away from more punitive measures toward a focus on treating addicts, not jailing them. Although, if you are caught trafficking as a predatory trafficker, your sentence, you must serve 50% of your sentence, and the sentence has been increased. Go ahead. So the role of the health departments is in one area, we're going to see, hopefully, naloxone in the schools. Shell Kreutzkamp and I were doing a presentation at a local high school, and we were talking about what they should do if they find needles while they're doing cleanups as part of their club work out on the grounds or on the streets. One local elementary school last year in their summer, spring, end of the year cleanup that they do every year, for the first time ever, they found needles. They found 15 of them on their property. So one of the kids at the presentation says, what do we do if we find one in the school? And I was like, you find them in the school? Yeah, they're in the bathroom. So hopefully we're gonna be able to have the nurses handling naloxone. Because if you're in a rural school and you call an ambulance, chances are that ambulance is gonna be at least 10 minutes out. And that's not good if you're not breathing.
I've started seeing, just like, I don't know what they're called, like the syringe disposal boxes in some bathrooms. Is there any law that, like, any laws surrounding that? Any laws surrounding, like, what kinds of places are allowed to have the syringe disposal boxes or
Those,
anything?
mostly in Ohio, you're seeing those?
I've seen them in Kentucky.
Yeah.
Yeah, like I've even seen them at the library, the Kimball County Library. So, I mean, I don't know if that's what they're intending them to be used for, but I wasn't sure if there were any laws or anything surrounding those.
No, diabetics are using and have to use, and maybe, I don't know.
There aren't any laws restricting those from having disposal units on their property or in their business.
Believe it or not, there's really no laws saying you can't just buy needles. So you and I probably could go in Walgreens and just say,
You can't, they ask for your ID and they take down your information,
Yeah.
just like they would if you bought Sudafed or something like that. And if you look strung out, they're not gonna sell them to you, it's up to the pharmacist's discretion.
Right.
Yeah, I used to work at a pharmacy, and we wouldn't sell them unless they had previously filled a prescription for
Oh, yeah.
insulin there.
Yeah.
The pharmacist just said he wouldn't do it.
When I was a patient, when I was going through my chemo and I had to take like these shots for my red blood and white blood cells, I got one to take home, because I had to dispose of my chemo.
Oh, sure,
Yeah,
sure.
so
They didn't put a port in.
I've got a port.
You got a port.
Yeah,
Yeah, that's, but still you'd have to give yourself the shot for,
in my stomach,
yeah.
yeah.
And you can also buy them in a feed store,
Yeah,
Tractor Supply,
Yep,
whatever.
that's the way a lot
Yep.
of people that are struggling get their injection supplies.
next slide.
I actually think that we've done such a good job, the health departments and others have done such a fine job in increasing the awareness about HIV and other infection kinds of things that are related to IV drug use or needles of any kind, that schools, libraries, and other public venues are taking those, what I would consider to be extraordinary measures of prevention to keep them contained, because they are finding them.
Right.
I mean, it was 15 on one school property, but I suspect they are finding them in the bathrooms.
Parking lots, the playgrounds. I tell people that my family had a family meeting a couple of years ago. And you know where the Veterans Park is.
Oh, yeah.
I was there. They were in the shelter and they asked me to take the grandkids out. And I walked over to the slide and my granddaughter's climbing up and I looked down, there's a needle right at the bottom of the slide. So, the syringe access exchange program, if they get off the ground, will be very helpful in removing the needles from our parking lots, roadways, and playgrounds. Go ahead. Now, I should say quickly about this. Local health departments in Senate Bill 192 are also required to assist with providing information on treatment. Go ahead. This is the one we're working on right now, syringe access exchange programs, and it has to be approved by the Board of Health. District Board of Health has to be approved by the county legislative body, fiscal court, and if it's operational in city, it has to be approved by the municipality or city council as well. All three have to approve the language of and the availability of the syringe access exchange program. But don't think of it just as a needle exchange program, because what it is an opportunity to test for HIV, test for hepatitis C, test for pregnancy, get vaccinations for hepatitis A and B, and a whole host of other harm reduction programs that can be embodied into that program. Go ahead. Now, our friends in DC, friends or foe? The enabling legislation for Medicaid only allow for facilities with 16 or less beds to get Medicaid reimbursement. You can apply for a waiver on that, but it's kind of complicated. Senator or Representative Fudge from Democrat up in Ohio is trying to get a pilot program to open that up so they can pay for more. Suboxone restrictions, Senator Markey and Senator Paul will have offered the TREAT Act, which would allow, instead of 30 patients the first year, 100, no limit after the first year for doctors, doctors, assistants, and nurse practitioners who have a background in addiction could also provide it. The Prevention, Treatment, Recovery Act I already mentioned, the federal funding for needle exchange. If you would have asked me last week what the situation on that would have been, I'd say our buddy Representative Hal Rogers, and I don't use that loosely, I worked with that gentleman a lot years ago in another life and another job. Great guy, but he had the idea that this needle exchange is enabling, and he didn't want to see any tax dollars spent for it. He has changed his mind. There's an article in the Wall Street Journal last Saturday, and you sent me he's actually proposed legislation or ruling that will release the federal funds to allow the needles to be paid for by the federal
Not
government.
actually the needles, but the services that
That's right.
the
Sorry,
exchange
thank
provides.
you. Yep. So neonatal study, Senator McConnell has offered to put up some funding for that. And then Southerners Kelly, I don't know how to pronounce that last name there, somebody named Joe Donnelly, Democrat in Indiana, have this bipartisan legislation directed towards treatment and preventing abuse. And that one might fly. It was in last year and almost made it. So, but there's no money attached to it. The other ones have money attached. Okay, and here's what money is. And that's what it was in 2014. So, I got another chart coming up. Go ahead. And this is, you can compare 2014 to 2015 and to 2016. Treatment goes up a little bit. Prevention goes down a little bit. Law enforcement goes down a little bit. Interdiction goes down a little bit. And then, so basically what I'm saying is nothing's really changing. Right? Nothing. There's no system change here. We continue to do what we always done. We'll continue to get what we always got. It's in the 12-step program, they talk about something like that, don't they? They say if you continue to do something.
Definition of insanity.
Yes, okay, well, there it is.
Yeah.
Repeating for the 3 years, go ahead. And this is the last known study on what it actually cost the country. They haven't done this, they haven't repeated this since 2003. But this number here is 600 billion now, based on estimates that are pretty, the extrapolation of other numbers, the increase in jail, people spending time in jail, the increase in the amount of drugs being caught. It's pretty well determined that that number is going to risen to $600 billion. What could we do with $600 billion? Go ahead. So, what are the barriers we face? In my opinion, the biggest barrier, go ahead, is peer pressure. The people I've met that are in recovery, the people I'm dealing with right now that are struggling, and my wife and I have deliberately moved into a neighborhood that was had a beautiful name, Wilson Lane, but everybody in the neighborhood called it Payne Street. And since we've been here 2 months, there's been 5 overdoses, 1 death, and then I can't count the number of times I have driven past police cruisers as they're making arrests. And you heard of a suicide by cop? I watched the boy last week commit treatment by cop. And I know for a fact he deliberately got himself arrested because he didn't feel like there was any other way out. Go ahead. So the single greatest barrier is, according to the HERT team, lack of funding. But again, in my opinion, I don't think that's so. I was working with coalitions when the Kentucky ASAP money was drying up quickly. And you know, I came on board, and there's all this money to spend, and we were spending money here and spending money there. Then all of a sudden, that was gone, and we had to raise our own money, and we got very little from Kentucky ASAP. But the creativity that came along with that, sometimes I think funding is not the answer, it's the creativity when you don't have the funds that can be the answer. I think the community involvement is where the real true answer is going to be. Go ahead. Stigma. I don't know how to get around that. The lack of collaboration. We have people, and Dr. Hedrick has been part of these talks, and so is Jason. And the first month I met with the Heroin Impact Response Task Force, I said, guys, you got to get over this turf. We're all in here for the same purpose. We want to save lives. We want to improve the quality of life of our community. Let's work together. But, you know, we have these silos of, I'm not pointing fingers at us, the prevention. You know, we have a right to, this is our work, this is what we want. But then there's a silo of treatment, and there's a silo of harm reduction, and everybody wanting a piece of the pie, and kind of jealous if one person gets more than the other. And then you got funders who pick and choose what they're going to put money into, and then that creates all kinds of strife and jealousy and silo picking and turf battles. So the lack of collaboration is a real issue that we are overcoming, I think. Go ahead. The lack of knowledge about opioid addiction and what contributes to it. If you read Senator Schickel's op-ed, you know that there's a lack of knowledge. It's embarrassing. And it's there for anybody who wants to go look for it. Go ahead. Lack of volunteers to address a complex epidemic. And I hope everybody in this class will eventually find their way into some volunteer organization and help make this a better place. Go ahead. Fragmented law enforcement boundaries. We're already seeing that kind of taking care of itself with this new regional law enforcement task force. Go ahead. Failure of institutions to fully engage. I think St. E's got blamed for this, but you know, institutions are like move at a snail's pace, and they have to really dot their I's and cross their T's, and they have attorneys that will block them every step they try to take, but they've really stepped outside and got Sun involved, and they got the Hesitant Betty Ford program going. So I think we're seeing some institutional engagement now. Go ahead. Political impotency at the local, state, and federal levels. We see some of our legislators right now want to backpedal from the Senate Bill 192, and we got to stay on them with advocacy to prevent that from happening, and even lobbying if you're allowed. The possibility of unintended consequences of the Senate Bill 192, and we're on that right now. Go ahead. And the last is sequestration. At the federal level, you know, we can't pay for it unless there's money to do it, and so it doesn't get done. What we need to point out to them is that what they're doing with that money is not so much a payment out as it is an investment into the future, where it won't cost us as much. We're going to pay for it one way or the other. Okay. Thank you. I think that's it. Go next. Oh, yes, there's my, those are the, if you want to write them down.
Actually, could you send us this PowerPoint so we can post it?
You got, yeah.
That would be great, because I need to have it larger, because of my vision.
Oh, no problem.
So that would be awesome.